Well, I wanted to welcome everybody who's joined us today. This topic of supporting people across healthcare and their own understanding of their role in healthcare, from mental health to primary care. I think we all know historically because of, well, first of all, stigma, and then because of the funding streams that are developed through our governments kind of all over the world, mental health has been kind of separate for many years from primary health care. And I think what a lot of us as people with our own lived experience have realized for a long time, we cannot separate our minds from our bodies and effectively support health. So this is such an important topic, especially because recently, as many of you probably know, our state has decided to go ahead with rolling out Medicaid reform that calls for integrating healthcare. So the earlier we can all be thinking together about these issues, the better we're going to be at offering our input in places where we can be welcome, but also just in supporting people in our local communities in a way that thinks across the barriers between mental health and physical health care. So we've got two experts on this issue coming to us in North Carolina today. Pamela Goodine does live here, and many of you probably know her, and Martha comes from out of state. But the cool thing is they met through doing a similar presentation together for the New York Association of Psychiatric Rehabilitation Services. And what they're doing is also in partnership with the Chicago Health Disparities Center. So you get some good information here from these two ladies. And I'll share a little more about Martha. She lives south of Boston, and she has directed a peer support training for 4 years, and she's also worked as a certified peer specialist on an inpatient unit. She's worked within peer-run organizations. She's facilitated groups in the Veterans Administration for the VA, and she currently works for the National Association of Peer Supporters, and they are one of the sponsors of this presentation. Martha is a member of the Recovery Focus Advisory Committee and the Veterans Stakeholder Council of the Center for Healthcare Organization and Implementation Research, better known as CHOIR, that's the acronym. Participation in these activities has given her a greater awareness of the research community, and she's been able to share her experience and be included in planning future research focus and opportunities. And she looks forward to sharing information on participatory research with her community. Pam Goodine, is a person in long-term recovery, and she lives here in Winston-Salem in Forsyth County, North Carolina. She's a strong advocate for the role of peer support and has co-founded the Precise Peer Support Development Group, which is a Facebook-based group. And she also has founded The Journey Continues Peer Supporting Peers Incorporated, which is a peer training resource. Currently, she works through the Forsyth County Public Health Department as a peer support specialist for our Stepping Up initiative, and she works part-time at Green Tree Peer Center here where I am. She is a certified RAP trainer, providing recovery and self-help education to many people, and she volunteers on many of local advisory councils, and she's always the voice kind of out front about the role of peer support in all these various areas. She received a statewide NC Hope Peer Support Specialist Award as Specialist of the Year in 2019. She's also part of the Patient-Centered Outcomes Research Institute as a PCORI ambassador. She represents a patient or the lived experience through her peer role for integrating care and ensuring minority populations are featured in the focus of the various patient-centered research studies. She's also done this presentation recently for NIAPers, and so I really look forward to hearing what they have to offer. And just as a quick welcome again to Green Tree Peer Center, where we we just are kind of having to be a jack of all kinds of different things. But that's the cool thing about peer support, where there's initiatives and hope, and you find a handful of others in your community, you can do great things even on a tiny budget. And we are necessary. So without any further ado, I present Martha and Pam. Thank you, ladies.
Thank you. Thank you very much. We're so happy to be here to talk to you today about peer support services being used to address the physical health and wellness needs of people who live with mental health challenges. And this presentation was developed by a dissemination team that was comprised of leaders from the Chicago Health Disparities Center at the Illinois Institute of Technology and the National Association of Peer Supporters, which is now known as NAPS. The Chicago Health Disparities Center is a group of investigators and persons with lived experience that examine the health and wellness needs of people with serious mental health challenges. The ultimate goal of the center is to improve the quality of health while simultaneously eliminating the effects of stigma on health conditions for persons with lived experience. NAPS is a national organization whose mission is to grow the peer support profession by promoting the inclusion of peer specialists throughout healthcare and other community systems worldwide. And our presentation is based on a view of hope and recovery. And this quote here, "Believe in yourself and all that you are. Know that there is something inside you that is greater than any obstacle." And I think that so applies to what we do in peer support. And just, you know, as sort of some housekeeping for this, we'd ask that you allow us to present, and then we'll have plenty of time for questions at the end. If you want to put questions in the chat so that you remember them, we'll go back through the chat and try to hit all those questions. We'll also be emailing everyone that registered 2 links. One will be to a survey. Since this presentation actually is part of a grant, that survey, we need to collect those for the grant. And I also have a link to a short quiz if you want to get a certificate that shows the contact hours. If you complete that quiz, I'll send you a certificate, and I'll have all the directions there with that. So without further ado, we'll move on.
Okay, good morning, everyone. My name is Pam Goodan, and I am a person in long-term recovery. I have a whole lot of experience working in this field for providers, etc. I've supported many people throughout their journey of recovery, and I'm just glad that you all chose to join us today to find out more about this important role of peer support specialists. We have nothing to disclose, nor conflict of interest.
Yes. Unlike what we often see in peer support presentations, we have to include this because this is actually part of a grant. But a little about me, you know, I'm in Massachusetts now. I was in the Air Force for 12 years before I was sidelined due to a variety of things that resulted in a psychiatric diagnosis. And, you know, for years, I was just a recipient of services. I just figured life as I knew it was over, and I got treatment. I wasn't really an active participant. I did what I was told, but I wasn't living my life until I found peer support. And I credit peer support really was saving my life, because it was the first time in many years I actually had hope that I could live a full life and not a limited life. And, you know, and that's why I'm so passionate about things like this.
Okay, so this presentation will review the value of peer support providers based on PCORI-funded research in assisting people with mental health challenges in attaining their health and wellness goals.
So you'll hear us talk about PCORI often, and that's the Patient-Centered Outcomes Research Institute. And PCORI helps people make informed healthcare decisions and improves healthcare delivery and outcomes by producing and promoting high integrity, evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. PCORI is a United States-based non-governmental institute. It was actually created in 2010 as part of the Patient Protection and Affordable Care Act, which we also know as Obamacare, or the ACA. These presentation materials, as well as Pam and I and other speakers that do this is all made possible by a Eugene Washington Award, a dissemination initiative proposed by the Chicago Health Disparities Center and the National Association of Peer Supporters. And just a disclaimer, all materials and comments are solely the responsibility of the dissemination team, and PCORI is not responsible for the presentation of the materials.
Okay, so here I want to summarize what will be reviewed in this presentation today. First, we will talk about the problem, the reason we are all here today. People with mental health challenges get sick and die 10 to 20 years younger than the same age peers. The problem is even worse if they are persons of color or from low-income communities. One reason is because health services that would improve health outcomes for this group are lacking and or fragmented. Second, peer support services are an effective solution in improving health care outcomes. Peer support providers are people from the community who help the patient take advantage of existing services. Peer support systems may engage the patient in shared decision-making skills, training, or community navigation. Third, these programs have been developed through community-based participatory research, also known as CBPR. In CBPR, individuals from the community in which programs are being implemented must be in charge of all aspects of development and evaluation. One specific community is persons living with mental health challenges. People who live with experience of mental health concerns work together as a team to develop peer support service programs. For example, if the program is being developed for an African American community, then the team of people with lived experience are predominantly Black. Fourth, research needs to show how well these programs work. PCORI has funded several research projects to do this. We review these projects in the presentation. Lastly, in an effort to move forward, we want to engage you in a discussion about the challenges that have been experienced in implementing peer services in your community and develop strategies to overcome these challenges.
Thank you, Sam. This is kind of the tone of the presentation. We've shifted from a maintenance-based model where the best that was hoped for was to maintain a level of symptom to control to a recovery-focused approach that emphasizes those with mental health challenges can and do realize many of their hopes and dreams, even if some symptoms remain. And effective programs and providers embrace approaches that promote hope, and they do it by empowering connection and collaboration. People with lived experience determine for themselves what services they wish to pursue to address their goals.
Okay, so let's look at the first point on the presentation outline. What is the issue? Specifically, what are health and wellness concerns of people living with serious mental health challenges? First, evidence-based practices show that the best journey to mental health improvement is through recovery-focused ideals. All the information provided in this presentation will be based on person-first language and recovery-focused approaches.
So what are the physical health concerns of people with mental health challenges? And before I push the next button so we see things pop up. I want you to take a moment and think of that for yourself. If you think about physical health concerns for people that also have mental health challenges, you know, what comes to mind? You know, are they very specific? You know, often, you know, without integrated care, they're treated almost as if they don't exist together. And so now as you see these pop up, you'll see that people with mental health challenges have physical health problems, or can have physical health problems affecting almost any organ system, any body system. I think we're real familiar with things like obesity and cardiovascular disease, diabetes. We hear about those things more, but people are also more prone to respiratory illnesses and problems with their digestive tract, such as, you know, irritable bowel syndrome. And they're also more prone to injury because sometimes they're not as stable on their feet and they fall, and there's a lot more injuries from things like falls. There's also more cancer. And, you know, one thing that's been evident through this COVID-19 pandemic is the increase how this community is more susceptible to communicable disease, infectious disease, like the COVID-19 virus. It has affected this community more than other communities.
Okay, so COVID-19 is a viral infection that causes respiratory illness that, when severe, can lead to death. People all across the United States have had to institute precautions to keep from being affected by the disorder. This includes sheltering in place, maintaining 6 feet social distance, and wearing masks in public. If a person believes they are infected, they should promptly be tested from a qualified medical professional. If they are positive for the infection, they should then receive treatment from the medical professional. Sheltering in place has led to significant stress and social isolation, which may worsen the mental health of people already vulnerable to psychiatric illness.
So when we talk about these kind of physical illnesses, if they're left untreated, can be negative results. People with mental health challenges use the emergency room more than their same age peers for physical health problems. They may become disabled and have limited mobility, along with the inability to meet personal goals related to education, work, or independent living because of the physical illness. They also may end up in an institution. And despite the fact that state hospitals have faded away because of deinstitutionalization, there's still state hospitals that exist, and many people that aren't in a state hospital institution may end up in nursing homes or other 24-hour care centers where they get the care they need that they cannot provide for themselves. And as we said earlier, people in this community get sick and often die 10 to 20 years younger than average.
In addition, physical illness undermines wellness. People living with serious mental health challenges report a lower quality of life because of sickness. Many are less satisfied with day-to-day activities. They report a lesser sense of peace, serenity, and calmness. They state experiencing a feeling of inadequacy rather than a sense of wholeness. We do not mean to say illness and wellness are separate experiences, that they are treated separately. Rather, they exist on the same continuum.
So before we go too much farther, we'll define some things, and what exactly do we mean if we say serious mental health challenges. And to be transparent, I actually changed this slide because it said serious mental illness, and I just don't like that characterization. But a diagnosable mental behavioral, or emotional disorder that causes serious functional impairment that substantially interferes with or limits one or more major life activities. That's the SAMHSA definition of serious mental illness. And the reason we bring this up is because it's not, what do we mean by disability here? And it's people have difficulty in achieving specified goals and goals they choose. They also often have substance use disorders and co-occurring disorders. Mental health challenges lead to disability due to facing difficulties to achieve goals related to education, work, independent living, relationships, and physical health and wellness. And this is far more encompassing than just the Social Security Administration determination of disability that is solely based on one's employability. This has to do with quality of life.
Okay, so the problem of illness and death among people in this group is worsened by several things. People of color with serious mental health challenges are likely to show more illness and earlier death. People who are poor have worse health outcomes, especially if they are homeless. Crime worsens health. Crime victims get sick more often, but so does the person who commits the crime, especially if they become involved in the criminal justice system. Excessive use of alcohol and other drugs worsens health outcomes.
So we're going to next address 6 reasons why this occurs and more in detail. And the first one is lifestyle. And when we talk about lifestyle, it's typically what we call modifiable health risks or behaviors that make health outcomes worse. And part of it being modifiable is there has to be choice involved. People often fail to eat from healthy food groups, and actually this may make health worse by their poor diets, high in fats, sugars, or fast foods. People not only need to know what foods are healthy, but they need to know how to access these foods. People who live sedentary lives can have worse physical health outcomes. Sometimes just walking every day can significantly improve wellness. I'm not going to go in depth about cigarette smoking, but there's been evidence for a long time as cigarette smoking is clearly detrimental to health. Also, unsafe sex and other behaviors, it can lead to infections like hepatitis B and HIV, but regular practice of safe sex, for example, using condoms, can reduce communicable disease. And as we've discussed, alcohol and other substances may worsen physical health outcomes.
Okay, the social detriments of health are particularly important in the determining experience of persons living with serious mental health challenges. These experiences may lead to trauma, which can further worsen the person's physical and mental health. Many people with mental health challenges because of their illness have a limited income and become poor. Poverty at its worst causes homelessness. Many people do not have a regular place to reside or housing security. They may couch surf, live in abandoned buildings, or live on the streets, using shelters only when the weather is overwhelming. This group is more often victims of crime, especially robbery and assault. They may also be more likely to experience domestic violence, most typically violence and assault from a family member or a lover or friend. This group also has more interactions with the law. Some of them end up in jail or prison without receiving adequate treatment or support.
So the third thing we're going to talk about, which is particularly relevant today as North Carolina moves toward integrated care, and it has to do with insufficient resources. We have a fragmented healthcare system. sometimes health and wellness are lacking because the community lacks the kind of resources it needs to provide quality care. Primary care clinics that are the entry into the healthcare system may not be in your neighborhood. Specialty care clinics are often missing altogether. Often clinics that are available cannot be easily accessed. This can be due to a lack of transportation, especially affordable public transportation. Insurance coverage, especially public insurance, is often lacking for needed and desirable services, so patients cannot access or pay for the care they want. Parity in insurance is equal pay for physical health and mental health care. Parity is often lacking, so the quality of mental health care lags behind physical health care. Recovery resources are often absent altogether. There is often distrust of the healthcare system due to past negative experiences. So even though it may be there, a person may choose not to access care because they don't fully trust the system. Together, these problems describe what we call the fragmented healthcare system.
Yes, and the fourth point that we want to reflect on is that many service centers and providers fail to address the needs of people in that community. Specifically, clinics often are not in ethnically diverse communities. They may lack service providers from ethnic groups of color that reflects the community. People want to receive care from someone that looks and talks like they do. This helps build trust in the system. Often healthcare services fail to reflect cultural priorities that reflect recovery and hope for this group.
This next reason, we would be really remiss to overlook. And you'll see this slide says medication side effects. I don't consider them side effects. All medication have effects. There's the desired effects, and then there's the other effects, which sometimes are very undesirable, that are often called side effects. But in reality, they're all effects. Some good effects, some not so good effects. Often psychiatric medication may unintentionally make physical health worse. For example, many psychiatric medications contribute to significant weight gain, which may lead to type 2 diabetes. This can also lead to high blood pressure and cardiovascular disease. Others can cause kidney problems. People and their provider team need to work closely to address these unwanted effects and balance these with symptom reduction with the person's truly informed choice.
Okay, so finally, some with serious mental health challenges have genetic predisposition or a tendency to develop serious physical illness, such as heart problems, autoimmune diseases, and diabetes.
So we don't want to just give you bad news. We do know that for most physical illnesses, there are effective treatments. Often evidence-based strategies, which means research evidence shows specific interventions are effective for specific illnesses. For example, we know there are effective medications for high blood pressure, or effective procedures for cancer, and effective therapy for broken ankles. We also know we have quality training programs for doctors and other healthcare providers, and for peer support providers. Hence, there are healthcare teams that have mastered effective treatments that can help patients deal with physical illness. The problem is that many people living with mental health challenges are not able to take advantage of those teams and treatments. One reason is because the perception that physical health teams are often unable to work well with people living with serious mental health conditions.
Okay, so we have just reviewed the sides of the concerns related to physical health and those living with mental health challenges. Let's now consider solutions. Specifically, we'll talk about the benefits of peer support services. In the next several slides, we summarize different versions of peer support providers. First, however, we summarize what is known about good treatment as the foundation on which peer support providers do their work.
So one of the problems we've discussed is that mental health and physical health systems are separate. Integrated care is a solution, one place where the individual can receive all health services, physical health and mental health care. This is one team that is able to address both mental health and physical health concerns. One place for primary care, specialty care, and mental health care. And peer support should be included. Integrated care is a great idea, but not yet fully realized. One reason may be that healthcare providers resist the call for integration. There are primary care providers that may say, I was not trained to work with people who have mental illness. The second reason is that insurance and government programs have not fully bought into the idea. They have not encouraged health providers to join together to form an integrated approach. But now we are seeing some insurance companies have increasing interest in developing models that employ one single care manager to coordinate the care for a range of medical and mental health issues. And the other thing, often in the early development of integrated care, recovery resources and services are left out of the equation and end up totally lacking.
So what do we mean about peer support providers? These are full and part-time employees who may or may not have a professional degree. They have lived experience with mental health challenges and often come from similar ethnic communities. They focus on hope, strengths, and recovery.
And what you see on the slide is the SAMHSA definition again of peer support workers. So we'll discuss briefly the basic values of peer support workers. We're recovery focused. We are hopeful and supportive of personal aspirations and choice. Our focus is on the relationship. There is no force or coercion in the relationship. We promote empowerment in life in general and more specifically in regards to health decisions. We support people to identify ways to achieve their health and wellness. Support is often provided in the community, but can occur in any setting.
Okay, so one ingredient to peer support. Peer support specialists share selected aspects of their life with the person that they're serving. This sharing establishes credibility and rapport. It also provides opportunity for a person served to learn possible ways they might deal with health concerns. This self-disclosure is often referred to as sharing one's story. The story includes some of the challenges that one faces. This is not a life story, and the peer supporter always can choose what they want to share or not. For example, many peer support specialists would choose to never disclose the specifics of a life trauma. Second is their journey of recovery and who and what has helped them along the way. Peer support specialists want to share their experiences with hope and aspirations. They want to endorse the importance of empowerment and self-determination in their life. Sharing what's worked for me or what's worked for others that I know can be very helpful. The person that is being served might learn concrete ways to address some of their needs. There are limits to disclosure. So peer support specialists must attend whether to disclose information that is helpful to the person they're supporting or whether they experience it as irrelevant. So we choose what we want to share. We only want to share it with the person if it may inspire them or encourage them.
So what do peer supporters do? And specifically in relation to our topic today of promoting health and wellness. We're going to talk about shared decision making. I prefer to call it supported decision making because as a peer supporter, I'm not making the decision. I'm supporting the person to make their own decision. We can also identify what skills may be wanted and needed and teach skills. And we also support people to navigate a complex healthcare system.
Okay, so let me describe shared decision-making more fully. Good healthcare focuses on hope and possibilities, not poor prognosis and bad outcome. Self-determination is key. Namely, persons that we're supporting decide for themselves what their healthcare goals are and how they might be achieved. They desire personal empowerment so that they can make informed decisions. There's a stigmatizing belief that people with mental illness are unable to make decisions like these. That congenital disabilities, for example, prevent them from being clear-headed and sorting out evidence for best decision. This belief is wrong, and peer support specialists are in the best place to challenge it.
So the peer supporter does not make the decision, but supports the person by helping them understand what the healthcare provider may have said by using non-clinical everyday language. Peer supporters help a person explore all options and use a person-centered approach so the person has all the information that is needed for them to make a decision about their own healthcare. If we move on to teaching skills, what does that look like? People with mental health challenges oftentimes may need basic information about specifics regarding their illness and setting wellness goals, and what are the corresponding treatment options. Peer support can help people create questions to ask their providers and role play visits with providers to empower people to be more comfortable in these situations. On this slide is some examples of the questions. They may want to know exactly what is this illness that I've been diagnosed with and how will it impact me in the future. People want to know what are all treatment options. There may be medications, in some cases surgery. There may be hospital-based therapies as well as lifestyle changes or even complementary therapies such as meditation or vitamins or acupuncture. So the peer supporter can help someone explore all these, and it's not that we'll have all the answers, but we can support someone to be empowered to get that information. We also support people's wellness goals by supporting them to develop concrete ways that the goals they choose may be achieved. I really like the World Health Organization definition of wellness, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity.
Okay, so peer support specialists also teach skills for self-management. People living with serious mental health challenges can benefit by learning about specific behaviors that might help them attain health and wellness goals. This may include stress management, behavioral strategies, such as meditation that decrease the anxiety of a situation. It may include medication management, sometimes focus on medication administration and track side effects. It can also include healthy eating strategies, as well as activities that help people reach their exercise goals.
We also talk about supporting people to make social connections in the community of their choosing. And, and I'd say one other thing about physical activity, it's helping someone to find a way to move that is comfortable for them. It's not someone else deciding an activity they should do. The third thing we mentioned was helping people navigate a complex system of healthcare. Part of this is giving people the opportunity to find services that they want and need. It might start with helping to locate services, finding out what's available to them, and that might be limited by their insurance. And I am imagining everyone's had that, where they've tried to figure out exactly what is covered by my insurance. And it's certainly not put out there in a way that's simple and easy to find. We talked before about creating questions, and we may even accompany someone to appointments if they wish. And if we accompany them to appointments, it's not to speak for them, it's to give them support so they're empowered to speak for themselves. We may go shopping with them in their neighborhood and pick out healthy foods together. We also may participate in wellness programs in their community. And the goal of that is not to always be with them, but to help them get introduced to other people so that they're not dependent on us either. Among many services, peer support specialists help people do the basic tasks of navigating their community.
Okay, so the peer support specialist has several sets of skills that assist in supporting a person so that they can better understand their health and wellness goal, as well as strategies to achieve them. Active listening skills are basic to all of these. Active listening skills are a set of principles and practices that allow peer support specialists to be present for the person and share with him or her the peer's perceptions of what the person is saying. The next step may be a goal setting. Using active listening, the peer support specialist helps people make a list of goals in which they wish to pursue in terms of health and wellness. Motivational interviewing is one way to promote goal setting. In this task, the peer support specialist assists people in analysis of the pros and cons of a specific goal so that they can better understand what needs to be done to achieve it. For example, if the goal is to eat better, to have a better diet, pros might include possible weight loss, better able to complete daily tasks, and increase self-esteem. Cons might include not being able to eat French fries as much as they would like, or having to travel across town to stores that sells fruits and vegetables. The strengths model seeks to help people achieve their goals by focusing on strengths, not deficits. Focusing on what the person already can do or can learn to do will promote growth within the individual. As an advocate, a peer support specialist works in favor of the person by providing support and promoting their interests. Ideally, we advocate with the person, not for them. Peer specialists only act as advocates at the request of the person that's being supported.
So what do these things look like right now? What are we doing during the COVID-19 pandemic? And it also, we're doing this right now, but, it applies in the future as well. And some examples specific to COVID-19 might be explaining guidelines for personal protection in common everyday language, and checking with the person to be sure that they fully understand. We might speak with them about how to check themselves for symptoms and what to look for. And we might get access to places to be tested. And most importantly is this last one, which having discussions about fear and uncertainty and stress and isolation. And since we're experiencing this ourselves, that's a way we can directly relate to someone and not only share our feelings around this, but things we have found to help us through this tough time.
Okay, so next we're going to address the role of research in program development. Of special interest here is the role of community-based participatory research in program development relating to public health goals.
So we're going to call it CBPR because it's a real mouthful. But this is really the sort of the crux of this presentation. Because it is about research and hopefully shortening the time from research till it's actually implemented in our community. And CBPR is based on the insight that programs that are developed for a specific community must include individual users of healthcare services from underrepresented groups in that community. CBPR is collaborative, where a group of people are working together and everyone on the team has a voice. Everyone brings unique strengths. The group as a whole has strengths, as well as what each individual brings and their specific expertise. In CBPR, the community decides what is most important to them. And the goal is, by hearing the voice of the community, the combined knowledge and actions for social change to improve that community. And it also helps to eliminate disparities because there is involvement of underrepresented groups in research projects. So disparities are more evident and there's a collaborative solution for that.
Okay, so Aspiring Change is a project that was created to address healthcare obstacles by involving African Americans with mental illness in all stages of the research process. So this program was developed in 2015 through a grant sponsored by PCORI, completed by the Chicago Health Disparities Center. This manual also comes with the workbook.
So what is the model that was used in Inspiring Change? There were 3 groups of people to work with community stakeholders and design the program. There were people with lived experience, the academic researcher, and the community advocate. First among these experts are people with lived experience, people with the health conditions for which specific care programs are being developed. There are people in recovery. These people should reflect the ethnic diversity of the community. Second are the community advocates, or perhaps service providers, who are the professionals and paraprofessionals who will be charged with carrying out the newly developed program. And third are the researchers, who are the people who have a sense of existing research literature from which ideas can be drawn for program development. The researchers also know the kind of measurement and method issues that are important to effective program evaluation.
Okay, the Inspiring Change program teaches teams about 3 types of CBPR. First, there is understanding the problem. The team might be curious why, for example, emergency room use is so high in their community. One way to answer this question might be development of a survey that can be handed out at local ERs, asking users for their perceptions about calls. Second is designing a solution. Based on findings for understanding the question, the team might develop a way to handle a community health program. For example, the CBPR team might develop a nurse helpline to provide at-home advice that might detour ER visits. The method here is a survey of ER service providers regarding needs to set up this kind of helpline. Finally, testing a solution. The CBPR team might develop a program evaluation project to test a newly developed program. For example, the CBPR team might ask itself, how effective is the newly developed nurse helpline in diminishing ER visits? This kind of evaluation might be done by counting change in ER visits after starting the nurse helpline.
PCORI resources, the Inspiring Change was used in 2 studies to develop a community-based healthcare program for people of color living with serious mental health challenges. Leadership qualities were outlined in the first project. And then they developed a second program called Leadership Training to prepare people with lived experience to be full partners on CBPR teams. The Leadership Training Program was a 2-day workshop that focused on the development of skills which people with lived experience might use in CBPR teamwork. And you can see on this list of topics, there were leadership styles and communication skills. There were skills about leading a meeting, because in this program, everyone is equal, so anyone might be called on to lead a meeting. They also discuss self-care, which we know is very important, and solving problems and managing conflict.
Okay, so PCORI has supported 7 projects on peer support services. We will briefly review these studies here.
So these 5 studies actually, and I know this slide is probably hard to read, but if I will also send a PDF of these slides, and it has active links on it, so you can click the link and actually go right to that study. But these 5 PCORI funded studies are specific to the search for, it addressed health and wellness needs of people living with serious mental health challenges. 3 of these have been completed, and the 2 others were still ongoing when we made this presentation. So today we're going to summarize those 3 that are completed.
Okay, so the first PCORI funded study we will review is conducted by John Brake from the University of Southern California, titled, Can People with Serious Mental Illness Help Peers Manage Their Health Care? The project tests the BRIDGE program compared to treatment as usual services. The BRIDGE program seeks to improve healthcare access, utilization, and its impact on self-confidence in managing one's health as well as overall health concerns. BRIDGE did this by having peers, people in recovery from mental illness, teach research participants health management skills. The BRIDGE program has a manual that was used to implement the intervention. The intervention is augmented by motivational interviewing, education about illness, modeling skills, and practicing the new skills through the assistance of the paraprofessional. The BRIDGE is a 6-month long-term program.
So we're going to get a little more research sort of language in here now. But in this research evaluation of the BRIDGE program, 151 people with serious mental health challenges were randomized to mental health care as usual, which we call the control group, or BRIDGE plus mental health care as usual. Data was collected at baseline, 6 months, and 12 months. The measures included the number of routine visits and screenings as an indication of engagement, and participants' perception of their relationship with their healthcare provider. Second, confidence in self-management was assessed by asking participants to report their sense of confidence in making decisions about their health. Third, 2 sets of health concerns were assessed: chronic disease, or the degree to which research participants were concerned about ongoing and persistent physical illness, and their overall perception of bodily pain.
So this graph shows change in perceived confidence in managing one's health care. Note a significant improvement for people in the bridge group, while those in the control group actually showed worse confidence.
And I just note in these slides, the bridge group is that solid orange bar, and the bridge group is the one that got peer support in addition to treatment as usual. The second graph shows their changing concerns about chronic disease. And the last graph is their perceived bodily pain. You can see people in the bridge group showed significant improvement in their chronic disease management concerns. In terms of bodily pain, this is what we call reverse scored, so that a negative change score actually means less perceived bodily pain. So once again, we see significant improvement in perceived bodily pain for the bridge group compared to the control group.
Okay, so the second PCORI funded study was conducted by Dr. Patrick Corrigan from the Illinois Institute of Technology, titled Peer Navigator Support for Latinx Patients with Serious Mental Illness. In an effort to be fully transparent, Dr. Corrigan, PI of this award that we are highlighting, is also the PI of the overall dissemination grant supporting our presentation today. This study, developed by a peer navigator program called PNP, using community-based participatory research, CBPR, a manual was adapted to train Latinx with lived experience to become peer navigators. In this case, peer service providers were Latinos or Latinas in recovery and living with a serious mental health challenge. They help research participants to better engage in health services. In the process, research participants were expected to better address their health goals. The key element of this peer navigator program was to literally walk the service recipients around the complex and fragmented healthcare system. The Peer Navigator program was a 12-month program that collected data at a baseline 4 months, 8 months, and 12 months.
In this study, there were 110 Latinx that had mental health challenges and current physical health concerns. They were randomly assigned to the PNP group or integrated care as usual. And just again, the PNP is, they got care as usual plus peer support. 2 sets of measures were collected. First, service engagement was assessed by counting achieved appointments each month. Second, perceived effects on health were measured by their reported recovery, empowerment, and quality of life.
Okay, so this graph shows changes in quality of life from baseline to 12 months. Once again, steady and significant improvement is seen in the PNP group, while quality of life in the ICAU control group did not really change.
And again, in these slides, the group that got peer support is the black dashed line, and the quality of life is that one centered on the bottom. The first graph on the left shows steady improvements in self-reported recovery for those that receive peer support. And self-empowerment measure is one that's also reverse scored, so lower scores represent more empowerment. Once again, you can see significant interaction that shows where those in the PNP empowerment improved over the course of the study, and the control group was relatively steady. Okay, so this is the last PCORI funded study
which is led by Cheryl Bellamy from Yale University and called Does the Peer-Led Program with Wellness Coaching Improve Wellness Among People with Serious Mental Illness? Using community-based participatory research, this group developed the Peer-Led Wellness Coaching, which is PWLC program. The PWLC was a 6-month program and included 3 months of peer-led groups, educating participants on personal wellness, stigma, and self-management strategies. In addition, program participants received 6 months of individual wellness coaching offered by a peer provider.
There were 74 people that entered this program, and there was what they call quasi-randomization in the design. So participants were assigned to different groups. 37 received PWLC, and their scores were compared to 37 others that received treatment as usual. Again, data was collected at baseline for 8 and 12 months, and there were 5 sets of measures collected, including the number of emergency room visits, participant-reported changes in alcohol use. General wellness was measured on how participants perceived their overall wellness. And the last 2 are participant-reported input into their treatment plan, and finally, self-reported satisfaction with treatment.
Okay, so this graph does not represent exact data, but demonstrates the general trends between 2 groups. Compared with participants who receive usual care, participants in the program showed fewer psychiatric or substance abuse emergency department visits, greater decreases in alcohol use, greater improvements in general wellness, more treatment plan, and greater treatment satisfaction.
So, and all you can see in here, all these findings were statistically significant improvement, with the exception of the self-reported alcohol use, which definitely was a positive finding, but it didn't meet the test for statistical significance. And you might be wondering, why do we care about this? And for me, why it's important is I still often get asked when I'm talking about we need more peer support is where's the evidence? Well, here's 3 research studies that show that the evidence of peer support combined with treatment as usual has better outcomes across the board. So here's the evidence. I often like to say, well, I'm the evidence. What more do you need? Well, here's more. So, and if you want more information on these, on the first one, the Health Navigator program, actually, if you go to that site, you can read all about that and download manuals. The second one that involved the Latinx population, they actually have the manual on their site that you can download. They have it in English and in Spanish. So again, when you get these slides, you'll be able to click on those links and go to those sites.
Okay, so we're now at the final stage of our presentation. We hope to involve you in a discussion on how to move forward. We want to address this dissemination, implementation, and the sustainability issues reviewed earlier in this presentation.
So when we created this, we came up with these sort of topics to guide questions, but we're open to any questions you might have. And one of the things we came up with is in order, like, there's all this evidence for peer support, so why isn't it available to everyone everywhere? It requires this shift in practice culture. We need to be better accepted by those who will be working alongside. It also requires a shift in what I'll call patient culture. I think we're used to, our culture is give me a pill to fix it and don't make me do anything. And I often will say, I want to lose a bunch of weight. Give me a pill that I'll lose weight and I can eat whatever I want and not exercise. I think we all know that's not going to happen. And that applies to our health as well. It's a collaboration. What can I get from my healthcare provider? And what's my role in this? What do I do for a better healthcare outcome? So the second one is identifying and selecting the workforce, training and certification of that workforce, supervision of the workforce, which is really important. It's really hard, and I don't know if any of you have experienced this. I used to spend a lot of my time in supervision trying to explain my job to my supervisor. And that's not what supervision ideally is about. You also need to be able to evaluate the program and figure out how it's working and what changes need to be made. And the final one is reimbursement. So this is all great. How do we pay for it? So what I'd like to do is sort of pause and leave this and see if there's any questions that come up around this, but also, questions in general. And I'm kind of looking in the chat, but I'd also invite you at this time, and I'll try to keep track here. I think you should be able to unmute yourself if you'd rather speak than be just in chat. And there's also the raise hand button. And if I see that go up, I think I can unmute you if you can't unmute yourself.
Hi, can I say something? Hello, Martha. Thank you so much for doing this, Pamela and Martha. This is Sabrina from the Union Mission in Roanoke Rapids, North Carolina. Now, I run a shelter, both men and women, and one of our problems down in this way is peer support. Now, I was a CPSS, and my associate director actually still is a CPSS. But one of the things I would love to do, we resource our people out to provide them with peer support. Unfortunately, I don't believe they get served correctly. It's not like when I was out there doing peer support. And the thing about that was, you said the proof, and I can tell you the proof because I was someone over 3 years ago that had a phobia of being out in the street, couldn't go around nobody. This man has now held his job and has become the manager in the last 3 years.
Yay.
I was with him and things like that. So it can be done. We do have to put forth that effort and give to them. Pamela, I too am a person in long-term recovery, both mental health and SA. So I'm just grateful for the opportunity that I have in order to give back. So what I want to do is I'm looking at this here, shift in practice, training and certification. I know about all that because I was certified. But I would like to bring that and be a provider here for the people here. So the big one is reimbursement. How do I actually be able to get involved where I can actually be or have reimbursement? Because we don't have enough, we live off of donations. This is how we used to buy our shelter, so that's my dilemma there.
And, that's common, we hear that a lot, and, and especially in something you're talking about where it's not even billable by insurance because you're largely working, not working with insurance and directly billing insurance. And that's where getting creative about funding and, I wish I had some excellent resources to share with you, but I'd say one thing. So if you can pair with another organization, and sometimes there's funding through things, or it can even be research funding, but research funding that seeds a program that then when they see how well it works, then they find ways to make the funding continue. And I think some of these presented, like the original program was for a small group, but it was funded. But then when they showed that it worked, they managed to find funding for it to continue, because people said, well, we've been doing this for a year. Look how great it is. You've got to figure out a way to pay for this now. And so sometimes that's teaming up. I don't know if like UNC or I mean, North Carolina is full of amazing universities that I'm sure have people doing a lot of this research. So it might be, and the other thing that's nice about PCORI, if you go on PCORI's website, if you just Google the PCORI, it's an open website. All research they do, everyone can read. And one of the problems with research, it gets published in a journal and you have to pay to read it. Anything PCORI does, any of us can go find it and read it. And you can also see like what kind of grants they have out there and see who has the grants. And you can look up, you can search by topic, you can search a whole bunch of ways, and you can see, I think you can even limit it down. You could say, is there anyone in North Carolina doing mental health research or whatever, and find out who's doing that. And that's a place to make an initial contact.
Great, thank you, I appreciate that.
Are there any other questions? I saw a question pass by and actually be answered, and it was about motivational interviewing, which, we talk a lot about. And the key to being really good at motivational interviewing is practice. And if you do like their full course on motivational interviewing, one of the parts of it is ongoing, where people that are trained in motivational interviewing get together and practice doing it. So you don't slip into the problem of turning into the fixer or setting the agenda. Because if you're really doing motivational interviewing well, it's all about the person you're supporting and you're just guiding the process. And it really takes finesse and practice and time. Lori, are you unmuted?
Yes. Yeah, my question is, in many states, the practice culture shift from a more purely medical authoritarian kind of model has not really changed very fast. And so I have two questions. Do you know of any states where that shift is happening in large part because of the activity of people who have recovered, developed life resilience, gotten vocal, and been welcomed? And the second thing is, in a state, a lot of our southern states that are kind of paternalistic in how they've done things, what do you think the value is in us as the peer community developing a practice culture, even when the funding streams and the policies aren't quite matching our being able to do a whole lot? Because my concern is if we wait for the practice culture to change at the administrative, at those levels where funding comes from, we set ourselves back. Do you know of any situations and cases where that work on the ground by peers who are really working hard together starts impacting policy and therefore funding?
Yes.
So maybe it's one big question, I guess.
Yeah, the answer to the first one though, like where are they doing this well? And, obviously I'm not an expert on every state. I wouldn't even be able to tell you by state. It's more like pockets within a state, because often, there's an organization. I'm in Massachusetts, and I can think of a couple of organizations that really do it well, but as a state, we're kind of up against the same thing. We're kind of low man on the totem pole and, get the leftovers or, end up driving doing other tasks that we don't want to do. And one I'll put out there, and at the risk of, I'm not saying this is better than any other, it's just one I happen to know about, is RI International. In Arizona, they've incorporated peer support throughout, and it's this real collaborative, everyone from the CEO all the way up and down the company knows the value of peer support and embraces that, and they have peer support involved even in leadership at all levels. And I think they're sort of an organization to look at to see how did we make this culture shift. And there's something to say from doing the work from the bottom on the inside, but you've got to get that shift at the top too.
Exactly.
And the other thing, as far as like doing the work, as we are there, I've been in jobs that I didn't particularly agree with some of the things I was asked to do, like it was in conflict with my values and ethics. And sometimes I like to describe it as my line in the sand. And this is different for everyone. What am I willing to do while I'm trying to make change? And what's my line in the sand? Where do I draw the line? Say, no, I'm not going to do that. And I think that's where it's different for every person. But I think right now we're in the position that we have to be willing to do some things that we'd rather not while we're trying to bring out that change. And, if we demonstrate that we're valuable and then slowly introduce different concepts and say, I have this idea and look, it's working here. I have seen that workplaces. There's also, and I'm not great at searching grants, but there's grants for grassroots innovative type organizations, kind of seed grants, and they're not a lot, but they're a lot of them right now because they come under social change and social justice.
Yeah.
And to be honest, peer support, we're part of the human rights movement. Whether we're out demonstrating or not, by supporting people with lived experience, that is social justice, because it's a community that's marginalized because of their diagnosis. So there are ways to get monies that they might not even mention mental health, but we are a marginalized group. And so sometimes these grants for social action really apply to us. And I say I'm not an expert on getting grants or anything, but it might be, trying to partner with someone that is, or someone that's interested in that, or even sometimes at local colleges, they might have a nonprofit center that helps people find grants.
Well, thanks. And there is also something to say for demonstrating, literally demonstrating, when you don't have the funds to work with until you act, meaning we opened a peer center on a voluntary basis, and it was open a few years before all of a sudden people started noticing the outcomes. And so now the county gives us enough money to where we're open half days and can do some actual peer support in the community. And I realize I'm not suggesting everybody work for nothing, and it's not easy and it's not fun all the time. But if we're not doing something at the community level that starts showing outcomes and catching attention, we may be missing out on some funding opportunities that are locally community driven. And so I wanted to encourage people to think about that. Ours is not the only county that pays for peer support in some specific ways that they know they can't get that kind of support through the state funded system and through the Medicaid system. So demonstration can happen because we refuse not to help. So, anyway, but thank you.
And the other thing, I guess my hope, my vision is that eventually we'll have what I call critical mass. There's enough of us and enough of our stories that they can't ignore it anymore. So even, you know, you can make little videos like people that use the center, and sometimes like radio stations or TV stations, local ones will run these little short like PSAs, and often, you know, if you explain it, you can do it really inexpensively or free, and it's just spreading the word, because we often rely on people wandering in and finding us. If they've never heard about peer support, they're not going to ask for peer support.
Okay, well, this has been a great presentation. I really enjoyed it, and I thank everyone for joining us. Doesn't look like there are any more questions, and look like the ones that were has been addressed. And so we're gonna go on and call it a wrap.
I want to thank you
Thank
all
you.
for attending today, and we are going to send Lori a recording of this, and like I said, a PDF of the slides, so she'll have that. And I'm going to email everyone that registered both a link to this survey and a link to the quiz. And so then you'll have my email, and you can do that. And if you want a certificate, we're doing this for 1.5 contact hours. That's what the certificate will be. And we hope you enjoyed it. And if you can think of another place that you think should see this presentation, please let Pam know.
Thank you so much, ladies. And the information is great. It's stimulating, and it's good to know that a bunch of us are hearing all this together across this state that we love so much. So thank you so much.
Thank you very much, Lori, for bringing us in today.